So I think just to introduce where I come from, work in the Birmingham Women's and Children's Hospital, Birmingham, which is around 120 miles from London, has got a big shopping area, has got canals, and apparently these canals are longer than the ones in Venice, but are not as famous. Got a symphony hall, and we've got mailbox, which has got plenty of shopping for you to come and visit us whenever you can. I don't have any conflicts of interest related to the topic of presentation today, but it's a difficult topic to cover because I'm sure that this is a wide audience of pediatricians, pediatric gastroenterologists, hepatologists, probably some adult gastroenterologists, adult hepatologists, surgeons, and maybe some radiologists as well. So I'm hope that I'll try and cover every aspect of the management of portal hypertension in children, and I hope that it will be sufficient, for each one of you to take something from this presentation. So the portal hypertension is defined as an increased blood pressure within the portal venous system. And as you can see, the portal venous system is formed by the splenic vein and the superior mesenteric vein, which joins to form the portal vein and then branches into the right and left branches within the liver. So their normal pressures are thought to be 5 to 10 millimeters of mercury. Portal hypertension is defined as when it is greater than 10 millimeters of mercury. And then there are some definitions of pressures which are there, which can vary whether you are talking about portal pressure or whether you're talking about hepatic venous wedge gradient pressure or whether you're talking about splenic pulp pressure. Don't go into it. But portal hypertension in children is definitely different from adults because in adults, some diseases, not necessarily alcoholic liver disease, but some other diseases are much more common than what we see in children. So that's why there are lack of rigorous clinical studies that inform our practice in the management of portal hypertension. The nature of liver disease and the progression of the liver disease that we see in children is dissimilar to that seen in adults. And we have limitations of techniques, especially invasive techniques to study this condition in patients' population at risk. So the difficulty in managing or decisions about management of portal hypertension is more high because we are extrapolating a lot of information about management of portal hypertension from adults. Even the pressures that I told you are from adult population. So you can ask whether the same pressures apply to a 2-year child as it does to an adult. We really don't know the answer to that. But yet, I think we continue trying to use information, which has been extrapolated mainly from adult studies. So I think that's why I'm saying that the many controversies which are surrounding the management of portal hypertension is really difficult to address and depends a lot on personal practice. The portal hypertension can then be classified conventionally into prehepatic, which is where extrahepatic causes of portal hypertension like portal vein thrombosis, intrahepatic, which is the most common type of portal hypertension that we see in the Western world, and posthepatic, which is congenital web, IVC, or Budd-Chiari syndrome, or any condition which is related to the heart. The intrahepatic is further divided into pre-sinusoidal, sinusoidal, and post-sinusoidal, but I won't go into the details of that. But important to recognize is that within the intrahepatic causes, there could be cirrhotic causes and there could be non-cirrhotic causes, which is termed as non-cirrhotic portal hypertension or portosinusoidal vasculopathy, which is now termed, and I will come to it further down during the talk. The causes of portal hypertension are many, but like I said, there are intrahepatic, prehepatic, and posthepatic causes. The intrahepatic causes can be divided into cholestatic diseases that mainly involve the biliary tree, or the hepatocellular diseases that mainly involve the liver cells, or a fibrotic disease of the liver, where the child may not be jaundiced, and yet they may have manifestation of portal hypertension, such as congenital hepatic fibrosis and Caroli's disease. And the prehepatic causes of portal hypertension are related to the portal vein occlusion or extrahepatic portal vein obstruction, which we see mainly with portal vein thrombosis, secondary to umbilical vein catheterization in a lot of patients, nodular regenerative hyperplasia, and portal venopathy, which are now again classified as portosinusoidal vasculopathies. And the post-hepatic I've already talked about with Budd-Chiari syndrome, inferior vena cava obstruction, and congenital and congestive heart failure. I'm sorry, but I wanted to just highlight that one of the causes which is quite important in the post-hepatic is the sinusoidal obstruction syndrome, which sometimes is seen secondary, to use of chemotherapy medications or use of some other medications. So what happens is that whenever there is a hepatic or an extrahepatic, there is development of portal hypertension. And when there is portal hypertension, there is back pressure. That back pressure results in opening up of vessels which are normally not open, and that results to the formation of varices in extrahepatic sites. So the main varices seen are esophageal, gastric, paraumbilical, and that's why you see prominent abdominal veins in the liver, on the abdominal wall. And also if the child has a stoma, you can see parastomal varices or in the rectum and rectal varices. And then subsequently leads to the development of ascites. So we've talked about what is portal hypertension. We've talked about the difficulty in diagnosing or making decisions regarding portal hypertension, a brief classification and the causes of portal hypertension, and also about what may happen with the development of varices. So what are the diagnosis and tests available for us really? The challenge is that the tests which are easily available are least accurate in the diagnosis, while the tests which are the most invasive are the most accurate in the diagnosis, going from physical examination, laboratory test, ultrasound scan, CT, MRI, fibroscan, endoscopy, and a hepatic venous wedge pressure gradient. And I'll dwell on these briefly as we go through the presentation. So what are the physical signs that you should be looking for in a child with chronic liver disease where you would suspect that there is portal hypertension? So one of the signs that can be easily missed is palmar erythema. I understand that it is much more easier to comment about palmar erythema in the Western population or in the Caucasian population, but still, the palmar erythema can even be seen in our Southeast Asian population. Spider angiomas can be something which you know. What is also important is to look for finger clubbing, but do not forget toe clubbing as well, which can be quite prominent in some of these children. Look for signs of hepatosplenomegaly, and I've purposefully put a photograph of a child who's not visibly jaundiced, because you see, portal hypertension can develop irrespective of jaundice, even in a child with chronic liver disease, and that is the point that I wanted to highlight over here. Excuse me. And there could be development of ascites. The other thing that we have to ask for, but we have to specifically look for, is melena. And in a nappy, you can see that this is black colored stool. Now it's very difficult sometimes because some of these children are on iron supplements as well, and they can also have slightly different staining of the stools. So it's quite important to make this differentiation of the iron containing supplements which stain the stools, as well as the melena, which is a black stool, which is really a medical emergency for us, for any child with portal hypertension. The laboratory values really are not useful in this assessment of portal hypertension. The few values that could be useful could be the platelet count, because with the increasing spleen, your platelet can be consumed, and there can be splenomegaly. The ALT and AST are very non-specific because they are enzymes which are present in the cells, and they do not directly reflect the changes in the pressure that are happening across the portal venous system. Albumin definitely can be used as one of the markers, because if the portal hypertension is quite significant, then that can lead to portal hypertensive enteropathy, as well as loss of albumin, as well as nutrition may not be adequate, and hence albumin may be useful. But INR and total bilirubin are more markers for liver disease than for assessment of portal hypertension. So in theory, the only thing which could be helpful really to give you an early indicator for portal hypertension could be your platelet count. So if we move from physical signs to some laboratory values to some imaging investigations, one of the imaging investigations that is carried out is ultrasound scan. And this ultrasound scan clearly demonstrates a good sized portal vein which is entering into the liver. The hepatic artery is by the side of the portal vein, you can see here. And in the CT scan, you can see the splenic vein and the superior mesenteric vein junction to form the main portal vein, which then branches into the left branch and the right branch. But when the portal hypertension is due to extrahepatic portal venous obstruction, then instead of a single portal vein that's going into the liver, you can see a leash of vessels which is surrounding the liver, the porta, which is then called as portal cavernoma. And this is clearly demonstrated on the CT scan, where you can see that these are all vessels which are grouped together at the porta at the site of entry into the liver, while over here you can see there's a clear portal vein which is seen. So if at all we want to do a CT angiography on these children, we need to ask for the correct investigation. And I think your radiologist will know, but it's still important for us to ask for a portal venous phase, but also a hepatic arterial phase and a late venous phase as well, because that may give us some additional information. And this CT scan just shows you a big spleen, which is there. I'm sorry, a big spleen, which is there. Some esophageal varices, which are scattered around the esophagus. And this is a nodular liver with some ascites around the liver. And you can see how small the liver is. This is an oblique view, so it's not giving you the complete picture. And these are all gastric, these white vessels which are surrounding the stomach are all gastric varices, which are seen in the axial views of the CT images. What does happen is the leash of vessels, which I had said and demonstrated around them, they cause sometimes obstruction of the bile ducts, and then they can cause what we call as a portal biliopathy, where the bile ducts start getting dilated. There is some wavy appearance of the bile ducts that can be seen, and the best way to demonstrate sometimes that is by MRCP, but you can do that on CT as well, when it is obvious. So if a child presents to you with an acute variceal hemorrhage, what do you do immediately? So that is a medical emergency. A variceal hemorrhage can be either vomiting of blood or black-colored stool. Both have same, both have the same degree of medical emergency that you need to tackle. So your initial ABC is important. You have to establish secure IV access and at least 2 cannulas, because once they start bleeding, then they can bleed like, I'm sorry to say, like a tap sometimes, and it's very difficult to control the bleeding. So that's why having secure vascular access is important, because they can go into a shock where it can be difficult to then get secure vascular access. You obviously have to do your labs, including CBC, clotting, cultures, and a group and save. And you always need to have 2 units of blood cross-matched in the blood bank for them, whenever they are under your care. You need to give them broad coverage of antibiotics. Need to give them PPIs, and you have to transfuse them to maintain the hemoglobin 7 to 9 grams per deciliter. What is quite important over here to remember is that you should not over transfuse them, because you may increase the risk of bleeding, as well as volume overload may itself cause problems, especially depending what the underlying condition is, and especially if there is associated chronic liver disease, because that can lead to more further fluid accumulation, further fluid overload, pulmonary edema. So you have to be careful. And there are no specific recommendations regarding INR and platelet count, but obviously if your platelet count is less than 20, you need to give, and if the bleeding is not stopping, then you need to give. FFP I would use cautiously in these children, again, because of the risk of volume overload, but it depends on the clinical scenario. The most important thing to control the bleeding in these is the use of somatostatin analogs called octreotide. And you need to start octreotide as soon as possible, 1 microgram per kilogram over 15 minutes, and then infuse at the rate of 1 to 4 microgram per kilogram per hour. And you need to continue this for at least 3 to 5 days with children with acute variceal bleeding. You do endoscopic intervention when stable within 24 hours. Please do not be heroic and take the child straight for an endoscopic intervention, really, if the child is actively bleeding. Because when you put the endoscope in, all you see is a lake of blood, and sometimes you do not identify the site of bleeding. So be careful. If the child continues to bleed, then you may have to consider emergency tips or use of a Sengstaken Blackmore tube, and I'll talk about that later. You do band ligation if the size permits or sclerotherapy in small children. And then you repeat it subsequently depending on your findings at the time of endoscopies. Just to give you a flavor of what they look like, this is how the varices look like inside. Usually the esophageal mucosa is quite smooth. It's not smooth really here, but it's quite smooth. But over here you can see these grape-like bulging varices which are seen. You then put a bander around some of them if you feel that they can be banded. And this is a varix with a rubber band around it at the end of the banding procedure. And this is gastric varices and fundal varices, which can be easily missed. And this is the endoscope, and endoscope going into the stomach and doing a J maneuver and looking back on yourself where you can see the fundal varices. And this is a situation where you really don't want to be in the operating theater, because this is a gastric varus which is oozing. And those of you who have been in such situations know that how difficult sometimes it can be to manage the situation. So the treatment could be by either endoscopic variceal sclerotherapy or by endoscopic banding procedure, which could be done. So the sclerotherapy, the endoscope, you have to put the sclerotherapy needle down then and inject into the varix. And the endoscopic banding is done with the help of a Cook's bander for us, but there are different banding equipment. And it's a clever equipment. So this is the endoscope. The bander sits at the top, at the bottom end of the endoscope with these rubber bands around it. So you put the endoscope down, you adjust it so that it is near the wall, you suck the varix in, and then fire the bander so that the bander goes around the varix. It's quite a clever mechanism who has devised it. If your sclerotherapy or uh, banding is not successful, then you could use hemospray, but it is generally reserved for use of gastric varices and not for esophageal varices, really. You can possibly use Sengstaken Blackmore tube, which is which has got esophageal balloon and which has got a stomach balloon. And what you do is you can put the tube. This has to be done when the child is intubated and ventilated. You can't do it in an awake child because this tube is impossible to get through. And what you do is you inflate the gastric balloon with water and you pull it against and you tug it against a gastroesophageal junction so that it compresses upon the varices which might be there in the fundus, because that's where the likelihood of most of the gastric varices develop. And if you have not been able to control esophageal, then you have to inflate air into the esophageal a part of the tube and then hold it against. What is quite important is once you secure it, it has to be secured with some suspension because you need to put pressure against it. And you need to release the pressure every half an hour or an hour, because that would help. Otherwise, it may cause necrosis of the mucosa inside. You have to then go in within 24 hours to try and actively treat the bleeding varix, which may be there. So you've done your initial management of your acute variceal bleeding, you've controlled it, you have done the endoscopy, and you've been able to control. When do you then repeat the endoscopy? And it depends on the grading of the varices, and depending on the grading of the varices, you can do it in a various protocol. But this is a BSPGHN guidelines, which is a rough guideline. I don't necessarily subscribe to the BSPGHN guidelines because there are some fallacies in it. But this is just in case you want to have some guidance to develop your own guidelines. This will be a good guideline, really to look at. The advantages of the endoscopic procedure are that the acute bleed success rate is quite high, which is 90 to 100%. It's a less morbid procedure, but there are disadvantages. especially the availability, because it has to be done by skilled endoscopists. And these endoscopists may not be available in regional pediatric centers, or even sometimes in tertiary pediatric centers, the expertise may not be available because you may not have a pediatric gastroenterologist or a hepatologist there, or your adult team may not feel comfortable in doing very small children. The disadvantages are also that repeated procedures are necessary. And in the countries like Sri Lanka and India, where the patient has to pay for every time the procedure happens, you have to be, decide as to whether this is in the patient's best interest or not. Does cause ulcers, stricture, and perforation as well, occasionally, if you're not careful and if you're not a skilled endoscopist. So, what are the complications that you can see of portal hypertension? And there are many. And mainly these are related to sometimes the hepatopulmonary syndrome and the portopulmonary hypertension are ones which are related to the underlying liver disease. But it is mainly the portopulmonary hypertension that you have to be really careful about, in your long-term follow-up of children with portal hypertension. So the hepatorenal syndrome, and you know that it can be of many types now. It's classified as type 1, type 2, type 3, and type 4. Ascites, which I'll talk about, not going to cover hepatic encephalopathy because it's not a complication of portal hypertension as such. It's a complication of underlying liver disease. And varices I've already talked about, and splenomegaly, think not much can be done apart from trying to treat the underlying disease really. So if you have ascites in a child, what will be your diagnostic and therapeutic approach? What is most important in a child with ascites is to see if there is fever or focal abdominal pain or frank peritoneal signs. Because what you do not want to miss in these children is a spontaneous bacterial peritonitis. It's a really difficult diagnosis to make because even after tapping the ascitic fluid, the yield is not very good. So that's why you have to consider, have a high index of suspicion and treat prophylactically with antibiotics. You have to evaluate for the hepatorenal syndrome, and you have to do a point of care ultrasound scan and an echocardiogram, which may be necessary to understand the hemodynamic stability of the child. It is important to decide whether you want to do a diagnostic abdominal paracentesis or not. But it is important that if you do an abdominal paracentesis, then you know how to interpret it. And I'll say about that in the next slide. But the real indication for a therapeutic paracentesis would be a tense ascites where there's a compromise of respiration, which is there. There is symptomatic pleural effusion or hydrothorax, which is secondary to the ascites, which is again compromising on the respirations. And those patients that are at high risk of varicose hemorrhage or with active varicose bleeding. One thing to remember is that if you have a child on whom you have done therapeutic paracentesis, you have managed them conventionally, and they really can collect their fluid very quickly and don't improve, then please think about hepatic vein thrombosis of Budd-Chiari syndrome. Don't think peritoneal carcinomatosis is that common, and diuretic resistant ascites and adjustment of diuretics may be necessary. So if you decide to do a diagnostic paracentesis, the paradigm of interpretation is changed since I was a medical student. Now we go on the basis of the serum ascites albumin gradient, and you calculate so you have to send a paired sample of the serum and then send a fluid, the ascitic fluid for albumin, and then calculate if it is greater than 1.1, it is most likely a transitate, and then think about what the causes could be depending on the protein content in the liver. While if it is less than 1.1, then it is likely to be peritoneal disease or exudative disease. Now, you can grade the ascites, and you can have grade 1, grade 2, and grade 3. And grade 1 is really mild ascites, which is only detected by ultrasound scan. Grade 2 is causing moderate symmetric distension of the abdomen, while grade 3 is causing a marked distension of the abdomen. And the grade 3 ones are the one that you really need to worry about. And you really have to give a good doses of diuretics in them. And usually we start with spironolactone and a combination of spironolactone and furosemide. We restrict their sodium, which must have done already. And then we decide, we give them 20% albumin infusion. We give them 5 mils per kilo of 20% albumin over 4 hours and give a furosemide halfway through the infusion. That helps in recruiting the fluid into the tissues, and the albumin infusion helps in increasing the osmotic pressure and causes excretion of the fluid. But despite doing all of this, there could be refractory ascites, which is compromising on the care, and you can give large volume paracentesis with albumin, really. But you have to ensure that you do not take a lot of fluid out, because if you take a lot of fluid out, there could be post-paracentesis circulatory dysfunction or PPCD, and then that would further compromise on the clinical condition of the child. Obviously, the child needs to be referred for liver transplantation, depending on what the underlying cause for the ascites is, or you have to consider the child for TIPS if it is feasible. So I think I've covered briefly about complications of ascites. I have talked about the management of ascites, and now I will try and talk about the medicinal treatment, mean what medicines can be used for the treatment of portal hypertension. And it all depends on what the underlying etiology is. And for that, for the varices, I've talked about endoscopic treatments. I will talk about balloon retrograde obliteration later on. But what is important is there are some medicines which can use because portal hypertension causes splanchnic vasodilatation and hypotension, and then leads to increased portal venous flow. So we can use non-selective beta blockers which can act at various sites and help in the management of this uh, portal hypertension. There are various treatments that have been used. There are vasopressin analogs. There is octreotide, which I already talked about. I don't think midodrine and noradrenaline are that commonly used nowadays. So what we have done is we've initially started with propranolol or nadolol as per the EASL guidelines and the Baveno 5 criteria, but we have now moved on quickly to carvedilol because that is what the recent Baveno 7 guidance is. So the carvedilol is a non-selective beta blocker. It's got an anti-beta and beta-2 blocker and an anti-alpha-1 blocker mechanism of action, and it does causes a decrease in the portal pressure by decreasing both the hepatic vascular tone and also causing some splanchnic vasoconstriction really. And we've found that to be effective. We start that with a dose of 50 mics per kilo, then in 2 weeks time go up to 100 mics per kilo, and a maximum dose which is given usually in the children is around 12.5 milligrams, depending on the size of the child, not in a young child, but in a slightly older child, you could give up to 12.5. That maximum dose for adult is 25 milligrams per dose, I think. We found that to be very effective in our population. By saying that, I do not have the evidence for that, but we have started using it. And it's really, again, we are following the adult guidelines, and only time will tell whether that's been effective really or not. There was an randomized control trial of carvedilol versus variceal band ligation that was done, and it did show that overall there was no difference in mortality, and this was done way back in 2009. But I think now the recent guidelines do suggest the use of carvedilol, especially in grade 2 varices rather than repeat endoscopic banding procedures. I've said that hepatorenal syndrome can develop in these children, and terlipressin can be used for hepatorenal syndrome. For control of acute variceal bleeding, it is quite important that you use octreotide. But if there is a hepatorenal syndrome that is developing, then you could consider terlipressin, but it has got its side effects. So be careful about its side effects, especially it can cause gut ischemia as well. There are now many more agents which will be available in the near future for the management of portal hypertension, depending on what a mechanism of or what etiology or the pathogenesis that we target. Statins could be used and has been some Obeticholic acid holds some promise over here. And there are other caspase inhibitors which are coming in the market, which could be used in the near future for the management of portal hypertension. Bacterial translocation forms quite an important role, especially the FXR agonists. And we will have some other beta blockers coming in the market soon, which for use of portal hypertension. So that's the medical aspect of treatment of portal hypertension. I did mention briefly about TIPS, and it's a transjugular intrahepatic portosystemic shunt, where this is a liver which is cirrhotic, and where there is a decreased circulation, there is portal hypertension, and there is no appropriate drainage of the blood into the hepatic veins, and there is back pressure because of the cirrhosis of the liver. And what the clever radiologist does is they put a stent which communicates between the hepatic veins and the portal veins, and then causes portal decompression and reducing the portal pressure which is there. There are some contraindications, and this procedure is quite a challenging procedure in children, especially because the portal vein size is small, the hepatic vein is small, the liver can be very hard. So it is not for somebody to do. You need serious air miles, to do this, and a lot of experience with these procedures to do this in pediatrics. The indications and contraindications for TIPS are as follows: that there is treatment of refractory ascites mainly, for esophageal variceal bleeding during acute management when the child comes with an acute GI bleed. If there is portal vein thrombosis and if the anatomy is feasible to do that, and definitely in some children with Budd-Chiari syndrome, it has been very useful. There are obviously contraindications for putting TIPS, and there are procedural complications. And the procedural complications are mainly related to accidental massive hematemesis because of bleeding that can. Post-procedural complications are quite significant, including the presence of encephalopathy. So we do start prophylactic use of rifaximin in these children, and they can also, if you have not, assessed your child correctly from a cardiac perspective, it can cause a further worsening of the cardiac failure. So TIPS has a role in children, which is quite used in experience center, but there are non-transplant surgery that can be necessary for management of portal hypertension, where the indications for shunt surgery are definite and some are relative. And I worry about the relative, especially when the patient demands a one-time treatment. But I would like to have a word of caution over here, because these shunt surgeries can be really difficult to do. Secondly, they can give rise to shunt encephalopathy, and especially in children with extrahepatic portal vein obstruction or portal vein thrombosis, where we do not know what the underlying mechanism of thrombosis is. These shunts can be quite prone to thrombosis again, and these shunts can thrombose. Sometimes these shunts are very difficult to investigate on an ultrasound scan and need repeated CT scan to see if the shunt is functioning or not. You obviously can do an endoscopy to check if there are varices or not. And if there are no varices, then obviously the shunt is functioning because the portal system is appropriately decompressed. But I would say that there are significant morbidity associated with the shunt surgery. So I would urge a caution before referring anybody to shunt surgery. Use of non-selective beta blockers is a well-established treatment now. And so I think that would be the first line of treatment rather than shunt surgery. There are various types of shunts which you can do. And in the interest of time, I can't go through all of these today, but I'll particularly like to highlight the Meso-Rex shunt. The Meso-Rex shunt was initially developed by John Deville, a good friend and colleague of mine who was in Birmingham and then has now moved to Italy. This was for treatment of extrahepatic portal vein thrombosis. Because the main portal vein is gone, over here and it is thrombosed. There is one of the internal jugular veins or the long saphenous veins can be used to bypass the area of obstruction directly from the superior mesenteric vein to the left portal vein. Again, this shunt is not an easy shunt to do. You have to identify that the left portal vein is present, and sometimes it may be seen on a CT scan, but actually when the surgeons go to do the procedure, they may find it to be technically very difficult. So you must have an alternative plan whenever you consider a Meso-Rex shunt, if at all you are going to do this. The Meso-Rex shunt, if successful, has some advantages over other shunts because the incidence of encephalopathy is significantly less because you are bypassing the blood. You're not bypassing the liver, but the blood is still going through the liver, so the incidence of encephalopathy is less. Also, it is speculated that the development of these children will be near normal because all the hepatoprotective growth factors, which are again bypassing the liver, are being delivered into the liver with the help of this shunt. So this shunt has some advantages, but the more important thing is to go with a shunt surgery, which the surgeon is most experienced with, really. So I want to dwell the last 5 minutes to talk about other concepts or newer concepts that are happening in the field of portal hypertension. And the most important things I have talked about so far are all invasive techniques. You take probably endoscopy, you take TIPS, you take shunt surgery. But what we want to try and do is try and see if we can predict and if we can manage portal hypertension appropriately. If we can predict and manage portal hypertension appropriately with some medical treatment and prevent the complications then and the progression, then that will be the most important achievement that we could do in this field. So there are some more now interest in fibrosis markers, in some endothelial dysfunction markers, which are blood markers, and different techniques which are used. Sadly, the serum markers of fibrosis which are being used to predict fibrosis or cirrhosis are suboptimal and cannot be used. But what is being used now is transient elastography or fibroscan measurements. It's a clever technique where it actually measures the stiffness of the liver. And the recent Bavino conference, really laid out the rules for how to interpret the fibroscan readings. Fibroscan readings in children can be really difficult sometimes because especially in the young children, because of the short intercostal space. So I think that's something that we have to think about as pediatric fraternity. So I think we'll have to think about, but just to give you the flavor of what's happening in the adult world, they measure the fibroscan. This is the 5 kPa, 10 kPa. The more higher the number, the stiffer the liver, which is there. What they have shown is that 25 kilopascals, the clinically significant portal hypertension is greater than 90%, really. Okay, so and if you combine that, what they have said is LSM less than 15 and platelet count greater than 50, there's a very low risk of clinically significant portal hypertension. So you can actually avoid endoscopy in them. But there is still a gray zone between 15 and 25 for clinically significant portal hypertension. And sadly, 40 to 55% really are in the gray zone. So what Dajti and their group have done is you do a combined Bavino 7 SSM model where you combine your liver spleen stiffness measurement with your splenic stiffness measurement and platelet count. And if you do that, then you reduce the gray zone to 7 to 15% of the patients with a very good positive predictive and a negative predictive value. So what about hepatic venous wedge pressure gradient? Because hepatic venous wedge pressure gradient indirectly tells you what the pressure is within the portal system, within the liver. And, depending on the level of the hepatic venous wedge pressure, you can speculate or you can postulate about the risks of pericial hemorrhage, the mortality, the failure to control bleeding, but it is an invasive technique. We don't have much experience of it in pediatrics, but now hopefully we will have some non-invasive measurement of hepatic venous wedge pressure measurement, where you can do it a virtual free hepatic venous pressure on the basis of some CT angiography, or on the basis of what they call as the shape estimation by an ultrasound contrast enhanced ultrasound scan. And this is something that we will have to keep a watch on and explore, because this would be very useful in pediatrics, because it would avoid the invasive part of the measurement of the hepatic venous wedge pressures. Gastric varices are particularly difficult to manage, and you can manage gastric varices by doing a glue injection. You can also manage gastric varices where there's a gastrorenal shunt, which is identified, where there is a connection within the gastric varice and the renal vein. You can approach that through the femoral vein and do a BRTO, or balloon retrograde trans endoscopic obliteration, or you can inject some coils into the gastric varix and stop them from bleeding. So there are various techniques now available to control gastric varices, and we can also grade them and assess the severity of them. A majority of them, which are low risk, can still be managed by just non-selective beta blockers. There are different now techniques of BRTO, which is, either there is a partial occlusion or there is a coil occlusion. So I think there are various techniques which are now available to manage them. Now, cirrhotic portal hypertension or non-cirrhotic portal hypertension, I did mention that there is a different classification. And non-cirrhotic portal hypertension is where, there are all manifestations of portal hypertension, but there is no cirrhosis. And you can see that the splenomegaly is much significant in them. The pancytopenia is then significant in them, but the liver enzymes are usually normal or mildly elevated. And this has now been classified differently, and there are various causes for the non-cirrhotic portal hypertension, which can be there. But now this is classified as portosinusoidal vasculopathy. And these all terminologies which were used in the past have been grouped together to call a portosinusoidal vasculopathy. And it depends on specific histological features that can be seen on the liver biopsy of obliterative portal venopathy, nodular regenerative hyperplasia, and incomplete septal fibrosis or cirrhosis. I think no talk is complete now without gut microbiome. And the gut-liver axis is going to play an important role, especially by the use of FXR agonists. So to summarize, if you have a child with suspected portal hypertension, you have to think about, actively managing them with non-selective beta blockers. And if you have a child with suspected variceal bleeding, then you need to start them definitely on some vasoactive drug therapy, prophylactic antibiotics, stabilize them, endoscopy, esophageal variceal bleeding, and then endoscopic band ligation and sclerotherapy if not feasible. And then continue to follow the algorithm with use of these vasoactive drugs, especially the octreotide, and start some long-term treatment on them. And in those which are refractory, consider TIPS or surgery. So to conclude, the management of portal hypertension is challenging because of the rarity and the lack of scientific evidence of best practice. There's significant morbidity and mortality, but it is lower than adults. And secondary prophylaxis is appropriate, but now with the use of non-selective beta blockers, we may have to adapt to using them more frequently. But I would again stress that management should be in consultation with a pediatric liver center and with a pediatric gastroenterologist or a hepatologist who is experienced in managing portal hypertension. There are so many avenues available for treatment that it is important to choose the right treatment for the right patient. And we hope that prevention and prediction will be more useful and more easier possible in the future. So I think thank you for your attention. And I'm very happy to answer any questions. There's already one question in the chat box. Thank you.
Thank you, Dr. Gupte. Thank you. That was a very comprehensive yet summarized talk on portal hypertension in children. and it was essentially an update. So thank you once again. So yes, we'll take up questions from this point. The first question we have is, how do you decide on splenectomy or splenic artery embolization in a patient with hypersplenism with stable liver functions?
Yeah, I think this is a very good question, and we struggle with this in our center as well. So, what our approach would be is, why would you want to do any intervention in a patient with, just because there is pancytopenia and stable liver function? So then what you have to think about is, sometimes you have to do that intervention to facilitate some other surgery. In those situations, we have not considered splenectomy, but we have considered partial splenic artery embolization. But I think our results have not been so good. The pain which these children experience following the partial splenic artery embolization can be quite severe. So what I would suggest to you is, evaluate the underlying cause for the portal hypertension and then manage it as per the cause. For us, because liver transplantation is easily available, we would consider a child with who has got sort of progressive liver disease with portal hypertension, uh, uh, you know, for liver transplantation. But we would not consider an elective splenectomy for these children, or splenic artery embolization. I think it also depends on what you're treating. If you're just treating numbers, then I do not think I would recommend that. It has to be a really valid reason for considering these treatments, like liver transplantation or like any other shunt surgery for these situations. I hope sort of that answers the question.
Yeah, thank you, Dr. Gupta. Yes, that does. One additional question actually related to that question. Could you just explain, is there any place for splenic artery embolization in preparation for shunt surgery?
No, I means in preparation for shunt surgery, no, I don't think there is again, the pain that is caused by this splenic artery embolization is quite severe in these children, really. And even if you try to do partial splenic artery embolization, sometimes splenic necrosis may happen. That may be a secondary source of infection in these children. And actually, these children have a compromised immune function. If it is related to an underlying liver disease, then it may just tip them over the edge and cause an acute and chronic liver failure child in your hand, which is associated with a high incidence of mortality. So I will not advocate that. Secondly, if you want to consider that as a shunt surgery, sometimes, but some of the shunt surgeries do involve performing a splenectomy in association with the direct shunt surgery as well.
Perfect, thank you. Yeah, you did mention about therapeutic paracentesis in your talk as well. Actually, we know there's a limited place for therapeutic paracentesis in children compared to adults, where in adult practice it's a quite common therapeutic intervention. So the question is actually, when you have to do therapeutic paracentesis, especially when children range from day 1 to 16 years, you would say their body size is different. So how would you recommend to replace the fluids? What's the maximum amount of paracentesis you may recommend, and how would you recommend the replacement of the fluid, the type and the amount?
Yeah, I mean, I guess that's a very good question as well, Mananti. What we tend to do is, we can go up to 50 mils per kilo at the first time, but then replace half of the fluid with 4.5% albumin. We don't usually replace with FFP unless and until the clotting is significantly abnormal. Secondly, we generally, if generally, we do tend to go around 20 mils per kilo maximum, but we can, like I said, in rare circumstances, go up to 50 mils per kilo with careful monitoring of the child. The other thing sometimes we do is that, and it may be tricky because in certain parts of the world, and I do appreciate it, is that we sometimes put in an abdominal drain, and the abdominal drain gives us slight more control over the fluid, and you can release it intermittently, and thus help the a child. The risks of having an abdominal drain in are those of infection, and they can be significant. So I think we do tend to use that, but as a last resort mainly.
Yeah, thank you. And I really admire that you're mentioning about using albumin over fresh frozen plasma because that does contain clotting factors, especially maybe in a child who has got a risk of or the tendency for thrombosis, and it's essentially a blood product. So it's true that it's quite costly to use albumin, but you talk about the ideal management, it's preferred over FFP. So thank you for mentioning that. One more question actually we have. You did mention about shunt encephalopathy. For shunt, you can get encephalopathy. Would you just share your experience about children who had shunt encephalopathy and what were the strategies you used to manage it?
Yeah, I mean, I think what we have done, we do a stepwise approach. Obviously, first is important to diagnose shunt encephalopathy, and it depends more on the neurological state of the child and also on the ammonia levels. Secondly, we do consider using lactulose regularly and making sure that the child is not constipated. Thirdly, we do use a non-absorbable antibiotic like rifaximin. And usually with these measures, shunt encephalopathy can be appropriately controlled in the majority of the cases. In the rare circumstances where it is still causing a lot of neurological problems, we feel that partial occlusion of the shunt that we have made can be possible, you know. And that's why when you do the tips as well, you have to have a careful discussion with your radiologist, because the tips should not be wide enough to cause shunt encephalopathy, but it should be wide enough to decompress the portal venous system. And because sometimes otherwise, if it is really a big tips that they put in, a stent that they put in, then you might have to partially occlude that stent in to manage the shunt encephalopathy. And if it's a surgical shunt, then usually it is managed with the medical treatment that I have said. And that is another reason why we have to be really careful about recommending shunts to our patients with portal hypertension, and we should try and manage them actively with medicinal treatment or medical treatment, as well as with endoscopic interventions as much as possible.
Great, thank you. We have actually another question which is related to splenic artery embolization. If you don't mind, the question is, would you recommend splenic artery embolization for children with significant splenomegaly and hypersplenism due to non-cirrhotic portal hypertension? I think it's mainly about the size of the spleen and hypersplenism, which you mentioned, maybe need a little bit elaboration.
Yeah, I mean, I guess this is also a really good question, and in the majority of the cases, the hypersplenism that is there does not cause any secondary problems. It does not cause significant thrombocytopenia. It does not, sorry, I mean significant purpura or significant petechiae. Yes, and the neutrophil count may be low, but it does not cause significant infections. So really the question over here is, what is the purpose for doing the splenectomy or the splenic artery embolization over here? So maybe that question needs to be clarified before you need to proceed with the splenectomy or splenic artery embolization. And personally, I would prefer really a splenectomy and a shunt surgery if possible, if that is the extreme that you're going, rather than splenic artery embolization. But that's a
Thank
personal
you.
view,
Yeah.
and we generally have go for that view. I maybe it is possible, Meranti, that we may not see as much non-cirrhotic portal fiber hypertension as much as you do probably in India and in Sri Lanka. And experience with splenic artery embolization may be more in your centers than it is in our centers. But whatever we have managed of the non-cirrhotic portal hypertensions, and we do see quite a large number of them, we have not been needed to do a splenic artery embolization in them or a splenectomy in them. We have then, if we have reached that stage, we have really thought about should we do a definitive treatment like a shunt surgery on them.
Yeah, great. Yes. Possibly the last question as we are running out of the time. I'll just speak of the question like as it is. Can I please know if anatomical variation in the formation of portal vein from SMV with narrowing of right and left branches result in portal hypertension?
I may not have understood the question. Would you mind
Yeah,
repeating it,
sure.
please?
Can I please know if anatomical variation in the formation of portal vein? The anatomical variation the person refers is to from SMV with narrowing of right and left branches, result in
Right.
portal hypertension.
Yeah, I mean, I think so. What I do know is, there is maybe, what the uh, person who is asking the question is alluding to, which I did not talk about today, was Abernethy malformation, or where there is a congenital absence of the portal vein, where yes, the splenic vein and the superior mesenteric vein may join together, but the portal vein is absent in some children, and that drainage of the portal vein may happen somewhere else. It may happen directly into the IVC, or there may be a congenital a portosystemic shunt which may be already formed. That is one. Apart from that, there are no anatomical variants that I know about. Usually the splenic vein and the superior mesenteric vein join together to form the portal vein, then goes into the liver and branches into the right and left. There may be, but because I'm not a surgeon, I may not. My apologies, I may not know about it. But there definitely is an entity called as Abernethy malformation, or which is now regrouped as congenital portosystemic shunts, where there is a congenital absence of portal vein, and the portal vein drains somewhere else. It could either drain into the IVC, it could drain directly into the right atrium, or it could drain into the hepatic vein as well.